We're doing a deep dive today into one of the most high-stakes moments in all of critical care,
Hmm.
that moment of apnea, between inducing a patient and then actually securing their airway.
Right.
For those few minutes, a patient is completely on their own, physiologically speaking.
And that gap,
hmm
that time where they aren't breathing, it's a clock. It's a timer ticking down to, well, to life-threatening hypoxemia.
So the question we're tackling today is, how do we extend that safe time?
Exactly.
Our mission is to really get into the weeds on the physiological principles, the advanced techniques that are used to maximize that internal oxygen reserve. We're going way beyond just, put an oxygen mask on the patient.
Yeah, this is about the math and the mechanisms.
Yeah.
We want to show you how a practitioner can take a standard lung
Okay.
and turn it into a sort of a supercharged oxygen tank.
Okay, so let's start with a number. If you're breathing room air right now, your alveolar oxygen pressure is what, around 100 millimeters of mercury?
About that, yeah. And we're going to show you how, with some applied science, you push that number to over 600.
A six-fold increase.
Six-fold increase. And that changes everything for patient safety.
So the foundation for this whole conversation is pre-oxygenation. It's about loading oxygen into the body's main storage tank.
Which is the air left in your lungs after a normal breath out. We call that the functional residual capacity, or FRC.
Maximizing what's in that FRC, that's the goal.
That is the entire game. But the problem is that reservoir is constantly being drained.
Right, there's this relentless physiological tax, you could call it. So if the FRC is our tank, we have to understand the drain.
And the drain is the body's oxygen consumption, or VO. A healthy average adult, just at rest, is burning through about 200 to 250 milliliters of oxygen every single minute.
And that demand doesn't stop just because the patient stopped breathing.
And it's immutable. It just keeps going. So every minute that passes, 250 milliliters of aero is pulled from the system to keep the body running.
But the patients who need this kind of airway management, they're very rarely average or at rest, are they? So that 250 milliliters is a best case scenario.
Oh, absolutely. This is where it gets really tricky. Any condition that revs up the metabolic rate, what we call a hypermetabolic state, it just cranks up that VRO and shrinks your safe time.
So what are we talking about? What are the big ones?
Well, think about pregnancy, especially late term. That raises consumption quite a bit. Or sepsis, a major trauma, even just a high fever.
So anything that puts the body under stress.
Exactly. Any of those can push the VRO way past 300, even 400 milliliters a minute. And the result is immediate. Your reservoir empties 50% faster. It just makes perfect pre-oxygenation that much more critical.
Okay, so understanding the drain really sets the stage for understanding how we fill the tank. How do we get pure oxygen down into the FRC?
For that, we have to follow the path of oxygen into the body. It's called the oxygen cascade.
The cascade.
Yeah.
It's basically the journey of an oxygen molecule, right?
It is. And it's a story of dropping pressure. The partial pressure of oxygen just keeps falling at every step, from the air all the way down to the cell. Our job is to make the starting pressure as high as we possibly can.
So break down that path for us.
Okay, so inspired air in the atmosphere starts at a partial pressure of about 150 millimeter Hg. But by the time that air gets into your lungs, into the alveoli, it's mixed with other gases, it's humidified.
And the pressure drops.
It drops.
Yeah.
To only about 100 millimeter Hg for someone just breathing normal room air.
And from there, it drops even more as it goes into the blood and out to the tissues until it finally gets to the mitochondria at less than 10 millimeter Hg.
Right, so pre-oxygenation is all about inflating that number in the alveoli, pushing that 100 up as high as it can go.
And the tool for understanding that, that's the alveolar gas equation.
That's the one. It's the math behind gas exchange, and it's what really shows you the power of breathing 100% oxygen.
So let's get into it a bit. The equation looks at atmospheric pressure, water vapor, CO, or the whole picture, right?
That's right. So 2UO equals pheno times. Well, it's a bit complex, but essentially it balances the inspired oxygen against the other gases present. With room air, where pheno is at 0.21, you get that baseline 100 millimeter Hg.
But this isn't just a theoretical equation, is it? It's sensitive to real-world conditions. What happens if, say, you're not at sea level?
That's a fantastic point. If you're in a hospital in Denver, for instance, the atmospheric pressure is lower, so your maximum possible PO is already handicapped before you even start.
Or if the patient has a high CO level.
Same problem. If a patient is in respiratory failure and their CO's high, that CO is physically taking up space in the alveoli, which pushes the oxygen out. The equation shows you the hard physical limits you're working against.
Okay, so with those limits in mind, let's go back to the power of 100% oxygen. We change that FAO from 0.21 to 1.0.
Well,
What happens in
the
the
clinical revelation. The PO absolutely skyrockets to 663 millimeter Hg.
Oh.
Just let that sink in. You have increased the pressure gradient, the force pushing oxygen into the blood by more than 6 times.
And that's what makes this whole thing work.
That's it. You're washing out all the nitrogen and filling that FRC with almost pure oxygen. You're supercharging the reservoir.
So we've established this enormous pressure inside the lung. Now, how does that pressure translate into actual stored oxygen in the blood?
And that takes us straight to the oxygen-hemoglobin dissociation curve.
Ah, the famous S-curve.
That's the one. And for this discussion, we are laser focused on that flat upper part of the curve, where the PO is high, above 60 millimeters Hg.
We call that the buffer zone.
Is the buffer zone.
Yeah.
And it's crucial because the curve is so flat up there. This means you can have these huge swings in the alveolar oxygen pressure.
Like dropping from 663 down to 100?
Exactly. A massive drop in pressure. But because hemoglobin is so saturated up there, your SPO, your pulse ox reading stays rock solid in the high 90s.
That's the time you're buying.
That is the time you've bought. The problem is what happens when you fall off that plateau.
The precipitous drop.
You hit that steep slope. Once your PO falls below about 60, every tiny drop in pressure causes a catastrophic crash in your oxygen saturation. That's when things go bad, and they go bad very, very quickly.
So when we talk about the total oxygen store, we're really looking at 3 places it's held, right?
Yes. Oxygen bound to hemoglobin, which is the biggest part, oxygen in the FRC, which we talked about, and then the third one, which is often forgotten,
Dissolved in the plasma.
dissolved in the plasma, and usually it's a tiny, tiny fraction.
So why does it matter here?
It matters because the amount dissolved is directly tied to the partial pressure. It's Henry's law. So at normal pressure, you have about 0.3 millimeters of ORO per deciliter of blood.
Pretty negligible.
Right. But when you jack that pressure up to 663 millimeter Hg, the amount of dissolved oxygen jumps to about 1.8 millimeter per deciliter.
A 6-fold increase there, too.
Exactly. So you're adding this extra little buffer, this extra bit of capacity in the blood itself. And believe me, when you're fighting for seconds, every milliliter counts.
Okay, now let's get to the clock itself. We have the drain, 250 millimeters per minute, and we have the store around 1,500 milliliter in a healthy person. Let's calculate the time to critical desaturation.
Well, the simple math is easy, right? 1,500 divided by 250. That gives you a theoretical safe apnea time of 6 minutes.
6 minutes? That sounds amazing. But that's not what we see in reality.
Not at all. In a real clinical scenario, even with perfect pre-oxygenation, you're looking at maybe 2 to 3 minutes.
So why the huge difference between the theory and the reality?
The main reason is that as oxygen gets consumed from the alveoli, there's no nitrogen there to sort of hold this open. We washed it all out. So the total volume of gas in the lungs actually shrinks, which causes the oxygen pressure to drop even faster. The FRC is the first and fastest tank to empty.
And that's what pushes you onto that steep part of the S-curve so quickly.
That's it.
And remember, this 2 to 3 minute window is for a young, healthy patient.
Yes. Now you bring in the high-risk patients, the ones whose lungs are already compromised.
The ones whose FRC is severely decreased to begin with.
Precisely. Morbid obesity is a classic example. Or significant ascites, fluid in the belly, or a term pregnancy. All of these things physically push the diaphragm up. They squash the lungs.
So the main reservoir is just smaller.
Dramatically smaller. And this is the most critical takeaway for anyone listening. In a morbidly obese patient, that safe apnea time can be less than 60 seconds.
Wow. Less than a minute?
Less than 1 minute. There is no room for error. You have to be perfect, and you have to be fast.
And that's what forces us to use advanced techniques. You have to go beyond the basics.
You do. Though the standard protocol is still the foundation. A tight-fitting mask, 100% oxygen for 3 to 5 minutes of normal breathing, or the 8 vital capacity breaths.
And you have to confirm it's working. You can't just guess.
No, never. You have to look at your monitor. The goal is an end tidal or an ADO of over 90%. If you're not there, you're not done. And positioning too. Head up, a 25 or 30 degree reverse Trendelenburg, especially for larger patients. It uses gravity to help you.
Okay, let's get into the advanced stuff. First up, non-invasive ventilation, or NIV. This is about physically making the reservoir bigger.
That's a perfect way to put it. With NIV, you're using positive pressure like BiPAP along with 100% oxygen. And that pressure literally stints open collapsed airways and alveoli.
So you're not just filling the tank, you're inflating it, forcing gas into parts of the lung that were closed off.
Exactly right. It's incredibly useful for obese patients, anyone with sleep apnea, or someone already in respiratory distress. It recruits lung volume that was otherwise unavailable.
But there are risks, right? You're forcing air into someone.
There are. You have to be careful. Too much pressure can inflate the stomach, which increases the risk of aspiration, or it can impede blood return to the heart and cause low blood pressure, so it requires skill and careful monitoring.
Okay, technique number 2, which is really a game changer for extending that time. High flow nasal oxygen, HFNO.
HFNO is
Yeah.
amazing. It delivers heated, humidified oxygen at these incredibly high flow rates, up to 70 liters per minute.
70 liters, that's a huge amount of flow.
It's a torrent. And it does a few critical things. First, that high flow creates a little bit of PEEP, some positive pressure, just like NIV, but gentler. Second, it completely flushes out the back of the nose and throat with pure oxygen.
The anatomical reservoir washout.
Yes. But the real aha moment with high flow is what we call permissive apneic oxygenation.
This is the truly mind-blowing part.
It is. Because the flow is so high, even when the patient is apneic, not breathing at all, that oxygen continues to flow down into the lungs. It diffuses into the alveoli just based on the concentration gradient.
So you're providing a continuous source of oxygen even during the procedure itself.
You are. It can dramatically prolong the safe apnea time. You're constantly topping off the tank while the body's draining it.
Is there a risk there, though? Could it create a false sense of security? You see the pulse ox staying at 100%, but the patient isn't actually ventilating?
That is the crucial analytic question. HFNO is fantastic for oxygenation, but it does absolutely nothing for ventilation, for getting rid of co-row.
So carbon dioxide is building up?
It's building up the whole time, leading to acidosis. The danger is staring at this BO monitor, thinking everything is fine, while another problem is getting worse. It's an oxygenation bridge, not a ventilation substitute.
So to tie it all together, pre-oxygenation is really about applied physiology. You're manipulating the oxygen cascade to create this huge pressure reservoir of 663 millimeter Hg, leveraging the S-curve's buffer zone.
And then for the highest risk patients, you use advanced techniques. NIV to physically expand the tank size,
Yeah.
and HFNO to provide that continuous replenishment.
Understanding this is the difference between having a calm, controlled procedure and a panic when the alarm goes off at 90%.
The difference between having minutes of safety versus mere seconds.
So we've established that in the most difficult scenarios, the patient with severe obesity and underlying lung disease, that safe time can be under a minute. It forces you to be aggressive. So here's the final thought for our listeners to consider. We know NIV is great for stenting the lungs open, for increasing that FRC. And we know HFNO is great for continuous oxygen delivery. The question is, how essential might it become to combine them? To use pressure support to maximize the reservoir's size while using apneic oxygenation to keep it full, creating the most robust, fail-safe bridge possible for that patient who is right on the edge.
That integration of high flow with positive pressure, it's a huge area of ongoing research for exactly that reason,
Yeah.
for those extreme cases. It's definitely something to think about as you continue your own deep dive into maximizing this vital oxygen reserve.